Hi, everyone. Well, that actually transitions really nicely. We're going to talk about medical education and what it means to be a doctor now compared to 20 years ago and what we need to be doing to train the doctors of the future. That will include rolling in big data and technology. And so we have two people here who think a lot about medical education. I have a lot of thoughts on it myself. I spent 7 years in the system. So we're going to try to distill it really quickly in 20 minutes. We'll try to get a question or two from the audience so you can be thinking about that. But I want to hit three key points among possibly others. One is the idea of a physician shortage. Two is residency hours. Do we really need to be working 30 hours at a time to be a good doctor? And then how technology is going to shape the role of doctors in the future. So let's start with the first question, dive right in. Is there a physician shortage? Some people say there is, some people say there isn't. How do you guys think about that?
So maybe I can start with that. So the AAMC has been generating data for the last 3 years. And we just came out with our third set of data, and it shows that there is a looming physician shortage. And it is for both primary care and for some of the specialties. And it is, right now we don't have a shortage, but as you project up to 2025 and 2030, there will be a substantial, in the range of 20,000 to upwards of 100,000 sort of physician shortage. So why is that? The population is growing, and importantly, the population is getting older. And older patients need more care. Even healthy older patients. My mom is the healthiest 88-year-old you would ever meet. She's in a walking club, she's in a writing club, and she has 7 physicians that she sees regularly. Now, if you think of the other 65-year-old or 75-year-old who has just diabetes or just hypertension or has had a surgical procedure, the number of physicians they're going to need to see and the ongoing care they're going to need is even larger. So the growing population, the diversity of the population, and the aging population are all important factors.
And Jim, we have actually had an expansion of medical schools across the country, whether it be novel medical schools such as thinking of the UT system, the Rio Grande Valley, who opened a medical school to take care of the underserved on the border population, but medical schools have recognized the need for more physicians and have built many since I was in medical school, but there hasn't been an equal expansion of the training programs, the residency training programs that those students will feed into.
Yeah, I feel like people are hearing that there is a shortage of doctors, and yet it is also really hard to get into medical school, and then hard to get into residency. So where's the bottleneck? Do we need more medical schools, more residency programs, and why do we not have?
So we've been looking at the shortage for almost a decade, and there was a call to increase the number of medical students enrolled about a decade ago for 30%. And between new medical schools and expansion of medical school classes, that expansion is we've at 28% now, projected to have 30% increase in a couple of years. So the medical schools have grown. The concomitant number of residency slots has not grown as much. And so we do need to expand the number of residency slots and the funding for that, and that would certainly help.
And that happens through?
So there's a complex funding, but there is government funding to support the GME slots.
Right. And is anything on the table now?
So the AMC and other academic health centers and hospitals have been really advocating for more government support for more GME funding. It's on the table. There's ongoing
Just
discussion.
Simply on the table. If it's not leaning one way or the other. Okay.
Yeah.
So I went to school at Indiana, and we had a bunch of different campuses, some of them in rural areas, and there was a track where you could actually apply to medical school and say, I want to be a primary care physician in rural Indiana, and if you agree to do that, then you get to go to school for free. That was a small program, only a few people were in it at the time. Are we seeing more ways of incentivizing people to serve underserved areas and to go through this training, which otherwise would leave them with a huge medical debt, to make it possible and desirable for people to do that?
And it is interesting that in the past, the way that you could get medical education paid for would be through the medical scientist training program. So in the era where we still train many physician scientists, where students would have not just their research graduate degree paid for, but also their medical degree paid for. So it is interesting that folks are recognizing that we need to train scientists, but also clinicians. And we were chatting before, Alison was describing some of these great programs that students have the opportunity to enroll in.
Because what you're highlighting is, so there's a physician shortage, but there's also a relative distribution problem. So that students are less likely to go to rural and actually inner-city underserved areas. So Indiana was one of the leaders, but a lot of other schools that serve states that have a lot of rural population have developed similar programs. And they do two things. They've actually developed branch campuses, so there's small areas out in rural communities, and students will immerse themselves in the rural communities, work side by side with a physician who's practicing there, and really see what it's like to be a physician there and get to know the community. And that's a great way then to have students feel comfortable with that process as well. So it's both the exposure and the potential for loan forgiveness also.
Right. So how is there an example from that Harvard is doing to sort of funnel people into specific tracks to meet needs, and or selecting people into medical school who might be more prone to, say, go into primary care, or, I mean, Harvard is not thought of as the major output center for primary care doctors, at least in my mind.
Although I think things have changed. When I was at Harvard from 96 through 01 as a med student, I would say that primary care was not the focus. Recently, through the development of the Center for Primary Care at Harvard, it really has grown, and students are finding that they can really become leaders in the field by looking forward to see what are the types of physicians that will be needed in the future. I will say that we don't have particular tracks that we accept students into, but we encourage students to get the tools that they need to be successful in the future. Those tools, for many of our students, will be another degree. So our students interested in policy will go to the John F. Kennedy School of Government. We have about 10 or so students a year go to the business school to get an MBA. We have some students getting a master's in public health to really try to train leaders to look forward to see, well, what kind of physicians are we going to need 30 years from now? And that's part of it. What skills do they need to be leaders to shape medicine in the way that we feel is best?
And building on that, so I was just at University of Kansas on Friday. I'm visiting that school. And they, one of their missions really is to train people to be rural physicians in Kansas. So they do have these immersive clinical experiences, work in the clinical world side by side with a family physician, but they also have a pipeline program. So they go out to Southwest Kansas, which is the most rural part, connect with the high school students, let them understand what it means to be a physician, and give them opportunities to sort of realize it's a possibility. And that's another part. So that's a single example. Similar example is going at University, Michigan State, University of Wisconsin. Lots of schools are doing that.
Right, right. So if the inevitable end seems, in some places at least, to be add more degrees, more time, more specialization. I mean, you finished med school in 01 and then went to 3 years of residency, and then 2 fellowships, and then we're practicing by...
You're sounding like my wife a little bit, who told me to get a job. All these special.
I think this is common among sort of people with a doctor in the family. We just understand that you're going to be 40 before you're actually doing the job. And then as things get more and more specialized, it seems like the medical system's answer has been, I'll just add more years onto it, have people also get PhDs, have people also spend time doing research, and that's wonderful and lovely, but I don't know if that's, I mean, is that the sustainable answer? Does it just keep getting more and longer and longer?
So I think there's a couple of trends. So more specialization has certainly been happening, and that does take more training. Another really important area that's going on in med ed now is looking at competency-based rather than time-based progression through education. So if med school is typically 4 years, residency is at a minimum 3 years. If you do competency-based, which is move forward when you are sure that you have those skills, can it accelerate individuals' time moving through? There are several schools that have begun to initiate this. AMC is actually leading a project with a pediatric program, so 4 different medical schools looking at exactly that, that if you really measure competency, can you move into residency sooner? The flip side of that is if you're really looking at competency, there are maybe some that you realize, oh, you actually are going to take a little bit longer. So this has been a little bit of a swing of the pendulum, which I think is really good, to ask the question, is it possible to potentially accelerate and still make sure that you're training confident and competent physicians that are really ready to move into that next step of training? So that if you read about medicine, medical education, this big area of competency is important. And it is potentially accelerating, but more importantly, it's making sure that as students move through, because you start out, you're a person, and then you become a physician.
You're no longer a person.
Through stepwise, through just a patient. Thank you. So, but if you think about it, you have to do that through supervised practice. And as you move through each step, as you did, you become more and more independent in the practice. And so the competency training is to say, how can we make sure that every student at every step of the way knows, I'm really skilled in this area, I've got this. This is an area I need to continue to work on so that we can tailor their individual learning so that at each step they're very confident and ready to move forward. Or to say, yeah, you need to continue to have more supervision in that space.
Yeah.
A side light is potentially accelerating.
And Jim, what that will take is to maybe even change the way that we're teaching our medical students. So, traditionally, way back before the advent of medical schools, was an apprenticeship model where folks would actually pay for lectures at Harvard Medical School, and they would pay for them. They would repeat twice a year, and you would sit. And that was, we moved into a very lecture-based curriculum where many of us for 2 years may have sat in lecture from 8 to 5. And the thinking now is, let's teach our students how to learn. The amount of information that we have, as we saw from the big data panel, is just enormous, and it's impossible to expect our trainees to know everything. You have to have a baseline amount of knowledge, but we're training people how to think rather than having them listen to us.
Yeah. So rolling in the idea that we would need to shift toward assessing competency as the mark for when you are qualified to practice medicine could seem absurd to people from outside fields. It's long been time has been the thing. But so then, how do you assess this competency? How do you know who is ready to be a good doctor? Especially when you're moving away from, it's so easy to write a board exam, say, okay, if you memorize these things, if you get this certain quantitative score, then yes, you are qualified. And as you're saying, and with big data, we're moving away from needing to memorize so much. The doctor can pull up, if I don't know all the interactions of a drug, I can pull it up right here and see, and if I don't need to remember it from pharmacology. So how do you assess when you're ready to be a doctor? Could someone,
I think Alison put it perfectly. You have to see it.
You just have to see it.
You do. And we many times look to other industries, and you look to the airline industries doing a lot of simulated flights. So it may be a combination of in our first and second years, we observe them with simulated patients. And we track particular communication, physical exam, clinical reasoning competencies. But it has to be direct observation, which is very different than just having somebody passively listen to a lecture.
Yeah.
It's gotten more, people still need to have good, basic, solid knowledge. You can't look everything up. You need to be able to have a conversation with your patient and be able to talk about the medicines they're on and know what that means. And you need to be able to formulate your plan,
sure,
as well as look at the data. So those tests remain important. But again, the idea of using more simulation, whether it is standardized patients, which are patients that are trained, and they can give you feedback and they can assess, did they take the history correctly? Did they get all the information? And then we look to say, can you put the problem together and come up with the right, what should I be thinking about? What tests do I need to order? And we can do that all in a simulated space. And then there's also high-tech simulation to look at the simplest procedures to the most complex procedures in a very controlled environment, which again really helps with training, but it also helps with being sure about assessment.
Yeah.
And then you still need to do supervised care and say, yes, you're doing this well. You can have a little bit more independence and freedom.
Yeah. It's an enormous challenge to think of how you could make a standardized test for, are you a good, compassionate, empathetic, good communicating human? But it sounds like sort of the task before you in some ways.
So standardized
yeah.
test is part of it. Working with other healthcare professionals and being evaluated is part of that. And so we're doing a lot more, in the workplace evaluation of residents. And it's physicians looking at physicians in training, but also beginning to have other healthcare professionals. So the nurses you work with being part of that evaluation as well.
That's a whole other part of the picture.
It's a really important part.
Well, I want to go to an audience question shortly, but I want to make some sort of pivot to the question of residency hours, which I hear about a lot, was certainly an issue for me. Amid this very long process of a decade of education and training, residents are often asked, and historically, and still today, asked to do shifts that go longer than 24 hours, often without sleep, often totally on the whole time in high-pressure, intense situations. Some people say that's contributing to physician burnout as residents or down the road. Maybe it's unsafe for patients. Should medical trainees be working 30 consecutive hours?
So that's a really complex question.
I know.
And what happened to the audience question? So, but I think you need to pull that apart a little bit. So we need to remember that residents, although they are caring for patients, it's in a supervised setting, so they always have backup. So that's one piece of it. And the other thing is we're training the residents to become independent practicing physicians. And so we need to make sure that they're ready to be able to do the work that they need to do to take good care of the patients that they need to do forever. And if you think about it, you probably have had an instance when you've had a family member who's gotten suddenly ill, or who was in the hospital and took a turn for the worse, or pregnancy, delivery went on for too long. And in each of those situations, there's potential ways that it can be. So do you flip over and say, your doctor's there, they're taking care of you, they've met in the emergency room, I've been here for 12 hours, I need to go home? Or do you want your doctor to say, you're here, this is a critical moment for you right now, let's get this sorted out, figure what's going on, I know you really well, we're going to sort this out, and then once you get settled, then move on. So right now, the way medicine is practiced, there are times, not in residency training, but just in the care of our patients, the people that we care about and care for, that we can't stop when the clock stops. And that will probably remain a part of medicine for the foreseeable future. So we need to make sure that our residents are equipped to understand, do they know their limits and when should they ask for help? And to develop the resiliency strategies that they need for that. Are the current hours the correct ones? I don't know. I have to say that the national groups that are involved in this are looking hard at that. They have been looking at the data about patient outcomes and about resident outcomes about the current hours, and it's an ongoing discussion. So those are the things we need to balance. Taking care of our residents and making sure they don't have excessive burnout, and it is a problem now, which is probably more than just how the shifts that they work, versus balanced with preparing them for the possibility of needing to do a really long operation, having a longer delivery than they expected, having a critical patient, you really want to get to that stable point. And that's the balancing act. Have we found exactly the right spot yet? Probably not. Do we need to continue to work on that? Absolutely. But I think those are the things we need to think about.
Yeah. Did you want to weigh in?
I think that the other thing is that we, at Brigham Women's Hospital, we did many of the initial sleep studies on resident hours, and you want to be safe. If everybody's probably had some type of all-nighter of some sort, and your brain just doesn't work as well after not getting enough sleep. So it is that finding that balance of making sure that you're able to take care of a patient, that the handoffs from one person to another are adequate, but that we're taking care of our residents as well.
Yeah, yeah. That's one of the top things that people say they want in their doctor is brain working well.
Yes, brain working well is important.
Yeah. We have time for a question.
Hi.
Hello.
My name is Susan Fendel. I'm with Mental Health Legal Advisors Committee. And we know that people with psychiatric diagnoses die about 25 years earlier than the rest of the population, and part of that has to do with stigma within the physical and mental health system and diagnostic overshadowing, where physical symptoms are attributed to it's all in your mind. We also know that the only really effective way of combating that stigma is not training, but consistent exposure to people who are stigmatized, who are also functional, who are colleagues, not per se people in acute episodes. So how can that be incorporated into training, not into training, but into the educational system for the medical profession?
Yep, I think that's a terrific question. You hit on a lot of really important areas related to mental health. And I would actually add there's a physician shortage in that area as well, physician and healthcare provider shortage in mental health. So what a number of schools have done, Washington University in St. Louis is one, and I actually think Harvard had done this as well, is part of the wellness program for the students. They include panels of physicians and often residents who have had personal mental health issues, and they will share those stories. And that does two things. It destigmatizes in terms of thinking about as a care provider and as you take care of patients. But also as a healthcare provider, there's a stigma to be seeking help. And that's an area that we're working on really hard. And so it's a double message that as a healthcare provider, seeking help is the right thing to do. It's a mature, healthy thing to do. And also it destigmatizes it when you look at your broader patient population. And more medical schools are bringing in, again, patient panels of people that may not be in the healthcare profession, whether it's mental health or other chronic diseases, and really sharing their stories to personalize it, and doing this early in the first year of medical school as students are just beginning to think about patients and patient care and their professional identity.
A final word on this, Dr. Saldaña.
No, I totally agree. I think it's, and no, we're out of time, super important that we start destigmatizing this from the first year of medical school, because everyone struggles regardless if you're a physician, not a physician, and it's really important to do that early on.
Thank you both so much for talking about this with me.
Thank you.
Cleared up a lot.
Thank you.
Thank you.